introduce our final speaker for this series. Thank you.
Well, good morning and welcome to Medicine Matters 2021 on this foggy February morning. This morning, we're fortunate to have Dr. Kenneth Rand as our speaker. Dr. Rand received his undergraduate degree from Harvard University and obtained his medical degree from Stanford School of Medicine. He was looking at pond water in the middle school science class that particularly sparked his interest in human biology and medicine. Dr. Rand did an internship and residency in internal medicine at Stanford, followed by a fellowship at the National Institute of Health in viral carcinogenesis branch of the NCI. He then returned to Stanford for an infectious disease fellowship. At the University of Florida, Dr. Rand has been a practicing infectious disease specialist, but along the way became the director of the hospital's clinical microbiology laboratory and the CLIA director of the whole Shands Hospital Laboratory. His research interests have been primarily in the area of rapid diagnostic testing, but have included work on antibiotic synergy, SARS Coronavirus, and the relationship between Epstein-Barr virus and multiple sclerosis. He is professor of pathology, immunology, and laboratory medicine at the University of Florida in Gainesville. Dr. Rand will speak on COVID-19 vaccine. Is it for you? Welcome, Dr. Rand.
Okay, well, thanks, Ed. Appreciate that introduction, and nice to hear some familiar voices. And thanks to the organizing committee for putting this together, and to Julianne, of course, for getting us set up. We had to do some backflips in order to do that. So thank you all. I have, for once, no financial disclosures or conflicts of interest. And so let's just launch ahead and just talk about where, in summary, we're going to head with this discussion. First, I'm going to describe the COVID-19 virus itself and talk a little bit about the viral replication, the virus's biology. We'll get into the epidemiology and show some graphic illustrations of how this virus is spreading around. And we'll talk about the clinical illness and go over, you know, what it looks like and if one should get, hopefully not, but if one should get symptomatic. And then that will be a sort of a longish introduction into the major COVID-19 vaccines and how they are constructed and how they work. And then we'll talk in a little bit more detail about the mRNA vaccines, because in part, those are the two that are FDA cleared at this point, and because that's what most of the people on the call have gotten. In this country, that is all you're going to get, basically, for the foreseeable future. That said, let's put this in some kind of perspective. Worldwide, we're over 100 million cases. In the US, it's pushing 28 million cases, with just under 480,000 deaths. That, to me, is just an inconceivable number. This is like Florida Field. If you've ever been to a football game and looked at all the fans, that's like 5 stadium full of people. It's unbelievable. Now, the graph shown below shows the incidence of cases in the US, and it took the form of 3 waves of infection. The earliest one was started in March of 2020, and we certainly felt that at Shands with the number of patients coming in. It was followed by a summer peak, which we thought, again, was the end of the world. It kind of leveled off and went down, and then another wave starting in November or thereabouts, and now tailing off. Alachua County, you can't even see the first wave, but I guarantee it happened. And they had an outbreak over the summer. And this is unfortunately a little bit cut off. This peak here is probably the students coming back to campus. And unfortunately, the far right-hand side doesn't quite show, but you would see another wave matching the national picture. So how did all this start? The earliest cases were in December of 2019 in Wuhan, China. It took the Chinese about a month to recognize that they actually had a problem. And it was something that they are very sensitive to because they had the first SARS outbreak approximately 20 years ago. I think it was 2003, 2004, which in my view miraculously went away on its own. And I don't know if that was the biology of the virus or what the Chinese were doing, but they certainly recognized they had a problem in January of that year. And then by the end of the month, basically, they had put Wuhan itself in lockdown, and then finally the entire country in lockdown. And they have controlled the virus in China that way. So this graphic shows what happened in the United States. You can see this little red in the New York City area early on, but it rapidly picks up in somewhat disjointed fashion across the country, depending on when the time is up here. And it's going to, and I don't know whether this cluster that's going to show up there is the Sturgis Bike Rally, but whatever it is, the number of cases per 100,000 people has rapidly increased and basically gone viral, and now affecting in somewhat patchy form the entire nation. Okay, so what is a virus? What actually is it? And what it is a sequence or a piece of DNA or RNA surrounded by a protein coat that either has or does not have a lipid envelope as part of its structure. And in one sense, SARS with COVID-19 does have this lipid coat. And one of the implications of that is that detergents and soaps and alcohols will dissolve that lipid coat and inactivate the virus. So that part is good. But either way, with or without the lipid, the virus has its proteins sticking out from the surface and uses those to get inside cells. And unlike free-living organisms like bacteria or fungi or protozoa, viruses can only replicate inside cells, whether those are animal cells, human cells, fish, even bacteria have viruses that can infect them. So it's a lot like a computer virus. It's code surrounded by a way of getting in and propagating. So this slide, I don't know how well you can see the bottom of it, but the bottom is to show the relative sizes of viruses compared with an ordinary bacteria. So at the bottom, we're showing an E. coli, and it would take between 10 and 100 million E. coli all packed together in a little colony to make a dot at the end of a sentence. That's how small bacteria are. And of course, you can see them, however, easily with a light microscope. we stain them and we can grow them and detect them. The viruses we used to grow in tissue culture, but nowadays we do all our viral detections by molecular methods, which I'll touch on in a minute. And the coronavirus, I don't know if you can see my pointer, I assume you can, is right in the middle in terms of the range of viral sizes, but the viruses are 10 to 100 times smaller than E. coli. And you can only see these or visualize them with the electron microscope or by some staining methods that allow you to see them under fluorescent microscopy. So this is a electron micrograph of COVID-19. And of course, the most striking feature of it is this halo of spike proteins, or corona, and hence the name. And so the virus was not actually named for the beer, nor was the beer named for the virus. But the spike protein makes it look like a crown, and so it became corona. The spike protein is key because this is the protein that attaches to our cells, to something called the ACE2 receptor, which is really well, we'll mention it in the next couple of slides, so we'll talk about it there. But just want to point out that this outer protein here is the target of the neutralizing antibodies that we believe are protective against infection. And this spike protein is the target that is in all of the vaccines because we want to induce antibodies to it. So this shows mechanistically or diagrammatically how the spike protein attaches to our cells. The protein in the center here, or to the left on the cell surface down at the bottom, is the ACE2 receptor, and that's a receptor that is involved in blood pressure regulation. There's a second protein on the cell surface that also binds, which has the function of cutting this spike protein off so that a mechanism from the virus can inject the virus into the cell. And so diagrammatically, what you see is the virus entering through that complex mechanism and then uncoating to release the viral RNA. The viral RNA goes in two directions, one to replicate itself, and the other to make the proteins that it needs to reproduce itself in the same exact form before it is released in the form of hundreds to thousands of copies for every cell that gets infected once it completes its cycle inside. So how does it spread and why are we seeing so many cases? Well, part of the explanation can be seen here. And so my ability to make clips was a little bit stretched by doing this, and so I don't have the technology behind it, but it is remarkable. And you can think of it as looking at your breath on a cold day outside, and also what people who smoke exhale with each breath. It kind of shows how these very small viral particles spread. And the viral particles, or the human particles containing the virus, have a range of sizes. The very biggest ones fall to the ground and don't do much, but the smaller ones, as you saw in that very dramatic video, can linger in the air. And and that's just from normal conversation, let alone coughing, singing, shouting, which will increase the amount of particles that we exhale. So to go back, obviously wearing a mask protects you, and wearing a mask, if you're the talker and recipient, protects you both and really minimizes the transmission. It's also important to recognize that most of the transmission, some 60%, is by people who are asymptomatic, that do not know they're infected at the time that they are transmitting the virus. Half of these roughly go on to become symptomatic, but the other half never get symptoms. And there have been a couple of studies that have followed people like this, so we know that that's what's going on. So what if you do get symptoms? What do you look out for? I think probably most people in this audience could come up with the list, but obviously fever and cough would be the main symptoms you would be concerned about. Sore throat, runny nose, and upper respiratory-like symptoms may accompany it. There can be some systemic symptoms, fatigue, headache, muscle aches that can be of varying severity. In some cases, almost incapacitating for a period of time, much like influenza. But the most important one in terms of seriousness is shortness of breath. And that is a reflection of not oxygenating your blood well enough. And unfortunately, we're blocking out part of the CT scan here, but what I've shown you here is CT scans. The dark areas are the lungs, in the middle is the heart and great vessels, and these little funny sort of oddball patches, what we call ground glass infiltrates, are actually what you might see in a very mild case of COVID-19. You can see a little more involved in this patient, and but I'm blocked out and can't see the far right there. But in patients who are more seriously ill, who have respiratory failure, who need to be intubated, basically the lungs just fill up with this inflammatory infiltrate so that they can't get enough oxygen, and that really is the most serious complication. But it's important to recognize this virus is also what we call systemic infection. And by that, what I'm getting at is these same receptors that the virus uses in the lung are present in blood vessels, all blood vessels. They're present in the heart. They're present in the GI, gastrointestinal tract, and basically everywhere. And so what can happen, you can get cardiac involvement with arrhythmias and then some inflammation in the heart. And we certainly monitor our UF athletes to make sure that if any of them get COVID, that they don't get this, and some unfortunately have. There can be abnormal blood clotting, and we've learned to manage that, but it can lead to pulmonary emboli and strokes. Neurologic complications are not fully understood, but many patients who are in this seriously ill category will get delirium. And then something that we refer to as cytokine storm, which just means a super overreactive inflammatory response to the virus, can also occur, can lead to shock, and can be very, very serious in and of itself. Well, again, my screen has cut off the over 80 group, but...
Oh, we can see it, Dr. Rand.
Oh, good.
Yep.
Okay. It's just me that can't. Well, great, because...
And you can move your picture down. You can grab your picture and move it out of the way if you need to.
Yes, that's a good idea. Should have thought of that. Thanks, Julie. Okay, so this slide shows the distribution of the effect of age on mortality. And the original data, it's hard to find current data on this, but the early data came from Wuhan, China, and suggested that the mortality was really super high in the oldest age group, but it obviously, the pattern is still going on today, and the older you are, the higher the risk is. So how do we diagnose this? What is our lab diagnosis? What does that look like? I think most of you are probably familiar with the infamous nasopharyngeal swab, which certainly feels like a brain biopsy, but isn't. It's unpleasant. Some people say it tickles. It's much more unpleasant than that, in my view. We can use saliva, but and we do for a lot of screening, but it's much less sensitive than doing the nasopharyngeal swab, which itself is not always perfect. There are rapid antigen tests, and one of these is shown here. I assume you can see it for whatever reason. Yeah, there we go. I can move that up. You can see the line in the rapid antigen test. These are even less sensitive than saliva. They're probably several orders of magnitude or less sensitive than the normal molecular tests that we would do in the hospital. But they do work for patients who are early in the infection. It'll pick them up pretty well, and certainly if they have high levels of virus, you would detect those with these rapid antigen tests. They're like an influenza test that the doctor does in the office. Antibodies, of course, can be detected in blood. We do have that available at Shands, and probably many other laboratories would have it. But that only tells you that the patient has been infected in the past. Doesn't tell you that they may currently be infected. So we'll look at that in a minute. A word about treatment. There is an antiviral called remdesivir. It does decrease the length of stay and lower mortality a little bit. It's better if you combine it with a drug that is an anti-inflammatory drug that's used in rheumatoid arthritis. We've also found that using dexamethasone, which is like prednisone, it further reduces inflammation in the setting of severely ill patients in the hospital. And that has also led to reduction in mortality. And then having patients lie on their stomach instead of on their back improves oxygenation and improves survival. So all of these things we've learned through controlled and trials that have been done one on top of the other during the pandemic over the past year or so. And as you can see from this case fatality rate curve, that's improved, but we're still stuck at around 2% mortality overall for serious cases. There are some treatments that absolutely don't work. Hydroxychloroquine has been the subject of numerous placebo-controlled trials. No effect whatsoever, I promise you. Antibiotics don't seem to help. Ivermectin, it's an anti-parasitic drug, probably not. Colchicine, another anti-inflammatory. Maybe there will be a role for it. We'll have to see. There have been some recent reports of miracle drugs from Israel. And again, these have been used in non-controlled trials. And that was one of the things that led to the thoughts that hydroxychloroquine would be effective. If you do non-controlled trials and you don't have very sick people, and they can get over the disease very, very quickly, and it makes it look like the drug worked. So yeah, we have to be careful and we have to wait for the controlled trials. Which brings me and you to vaccination. And so there are a number of different strategies that companies have used to produce a vaccine. And many of these go back a long way historically. This slide starts with the mRNA vaccine structure. I'm going to come back and spend more time on that. Again, as I said, because that's pretty much what we've all gotten. But I want to note that live attenuated viruses, that was the first vaccine ever developed. That's what Jenner used. He got it from a cow, and the cowpox did prevent smallpox, but that was essentially a live virus. It is a live virus. It was essentially the principle that if you pass the virus in another animal or in a cell culture, it can become non-fatal or less virulent, and therefore be used as a vaccine. So our current measles, mumps, and rubella are also live attenuated viruses, as is the chickenpox vaccine in children. You can kill the virus and use an inactivated virus, and that, of course, was the basis of the Salk polio vaccine. The Chinese coronavirus vaccine is also using inactivated whole virus. And you can purify out individual viral proteins, which is what your hepatitis B vaccine is made from, and also diphtheria, pertussis, and tetanus. And Novavax has adopted that approach. And finally, there is another molecular technique that has been developed in which the viral surface is replaced by a harmless virus, adenovirus, that causes a common cold most of the time. And the viral gene has been, or genes, or virus itself, has been replaced with a DNA copy of the spike protein, and then it uses the adenovirus shell to get inside cells. And AstraZeneca, you've probably heard of the Oxford AstraZeneca vaccine, Johnson & Johnson, and then the Russian Sputnik 5 are all using this structure or type of virus. So I'm going to move now to the mRNA viruses, or vaccines rather, mainly because that is what's FDA cleared here in the US. As you can see, there are two main manufacturers, Pfizer, Moderna. Both require 2 doses. The Oxford vaccine, DNA in an adenovirus shell, two doses. The Johnson & Johnson version of this, only 1 dose, and Novavax subunit vaccine requires 2 doses. So this diagrammatically shows what the mRNA vaccines look like and how they work. The M stands for messenger, that's for messenger RNA, and the messenger RNA sequence is actually put inside of a lipid coating. So the vaccine essentially recreates the virus itself, but you have to do that to protect the RNA because it would otherwise be degraded very quickly by your cells or by body fluids. But the messenger sequence is actually in the nanoparticles that are in the vaccine, and that sequence has been modified so that when the body translates that mRNA into proteins so that you can make antibodies to the proteins, these proteins have to fold in exactly the right conformation. That's a critical piece of the vaccine technology, which obviously both Pfizer and BioNTech and Moderna have figured out. And so here's our vaccine with its lipid coat, and it's being injected into your arm, which hopefully didn't hurt too much. And then it gets into local lymph nodes where it gets inside the cells and the lymph nodes, and it says virus, but translate that into the vaccine. And then when it's in the white cell takes that mRNA and turns it into protein, and then expresses small fragments of that protein on the cell surface. And these fragments then stimulate both T cells and B cells to make antibodies, T cells to produce what we call cellular immunity, which is the immunity that normally would keep you from accepting a transplanted kidney or something like that, but which is necessary for control of viral infections. And so one of the most spectacular aspects of these mRNA vaccines is how fast the manufacturers were able to produce them. To me, it's mind-boggling. You know, it took Pasteur years to produce a rabies vaccine, and he didn't have to do any clinical trials. But from the time the sequence was available back in January of 2020 until Pfizer and Moderna had prototype vaccines was 2 months. I mean, that is, to me, amazing. And then they gave it to people and it worked. They got, as I'll show you, antibodies and cellular immunity with those prototype vaccines. And they were good enough to get into phase 3 trials with 30 to 40,000 people by this summer. So an utterly spectacular time frame, and of course FDA approval November, December, or I should say FDA clearing. When you look at the 2 trials, Pfizer enrolled almost 44,000 people, Moderna 30,000, multiple sites across the United States. The Moderna was somewhat more accurately, I guess you could say, balanced for ethnicity and the racial groups across the US. And they both had quite good representation in the older age group, which of course is obviously the most important subgroup, right? Okay, so $1 million question, do they work? And of course, as we've indicated, if they're going to work, they have to produce antibodies, they have to produce cellular immunity. I'm not going to show you the cellular immunity, but just tell you it does do that. But I'm going to show you the antibody data because they kind of work in parallel. And so here's what an antibody response normally looks like to a viral infection, and to COVID-19 in particular. It takes about 10 days before these antibody levels start to go up. Then they peak out after a few weeks, several weeks, and then they tail off. And how long they last is still an open question. I'm not going to go into the different types of antibody, but neutralizing antibody is among these and is usually in what we call the IgG portion. Okay, so here is the first data that Pfizer presented using their 30 microgram dose, which is what you got if you got Pfizer. And basically, before the vaccine and a week after the vaccine, no antibodies. There was some beginning response on the day after the second dose. A week later, it bounced way up, then came down, just like we saw in the diagram. And it matches pretty well what convalescent serum or convalescent patients have in terms of neutralizing titers at the same time after infection. So that is very, very promising. For the Moderna, basically the same data, you start to see a response. It looks puny compared to the peak, but it's there even by day 15. And it, in the case of the Moderna, there was some data going out 4 months, and the antibody levels were maintained out to that point in time. And again, in the same range or better than convalescent titers. Okay, so here it is. In my view, this is the most spectacular demonstration that these vaccines work that I could imagine. I mean, I didn't imagine I'd ever see data like this. But the red is the placebo group, and the blue is the vaccinated group, and we're showing the Pfizer product here. And what you can see is that for the first 10 days or 12 days, the two curves overlap. They're identical. There's the same, but the placebo just keeps on getting COVID. So these are people vaccinated in the trial, sent out into the real world, and they come down with COVID-19. And the vaccinated group, starting on day 14, shown enlarged here, just the curve just goes flat. So each one of these dots is a person, and there just are extremely few infections in the vaccinated group. And to be counted, the person had to be symptomatic. So there was not screening done to look for the virus in asymptomatic infections. And undoubtedly there were asymptomatic infections, but there would have been more of them, of course, in the placebo group. But this is a spectacular demonstration of the effectiveness of the vaccine. And the effectiveness starts when the antibodies start to be produced. And the Moderna data look essentially identical. If right around day 14, the curves start to diverge and you get protection in the treated group, but not in the placebo group. Okay, so everybody is worried about side effects, and yes, there can be side effects, of course. The sore arm shown here, and I've shown this for the over 55 age group. For the younger group, the symptoms were actually a little bit worse, but there's definitely a sore arm that people get from this in significant excess compared to the placebo group. So likely that you will get a sore arm from it. And it wasn't much different between the first and the second injections in the in these data, but that may be very individual. What about some systemic effects like fatigue and headache? So those two are much more common after the second shot than after the first, although they do occur, and they exceed what the folks in the placebo experienced, as you would expect. And fever, much lower and relatively uncommon after the first shot, but definitely there, certainly statistically much more often than in the placebo group, but only 10 or 11% got any kind of fever, and high fevers were pretty uncommon. So what about rare, less common reactions? And I think anaphylactic reactions are the ones that have made the news and gotten people's attention. And so this data allows you to see exactly how, when these anaphylactic reactions have occurred. And I will say there is a definite female excess. It wasn't 100% in the Pfizer group. They had 21 reactions out of almost 2 million doses. So that's really low, but it is real. And the rate was 11 per million doses, which is perhaps 10-fold higher than what you would get from people getting an influenza shot. So it does occur, but it's really uncommon. And on a statistical basis, almost all the reactions occurred in 15 minutes, although there were some that occurred within 30 and even some delayed reactions. Now, anaphylactic reactions are the ones that involve the throat feeling constricted and wheezing and having difficulty breathing. Those are the serious ones. Many of these patients, if not all, were taken to the hospital as a precautionary measure. I think some of them did, have to be intubated, but everybody survived. There were no deaths in this group, and I think that is another important fact to recognize. The non-anaphylactic reactions, those are going to be mostly skin rashes, hives, and itching are probably the most prominent. Those also occur early on for the most part. The Moderna vaccine, in this case, almost all the reactions were within 15 minutes. All were women, unknown why, and a similar distribution, but a somewhat lower level in terms of the rate per million doses. But it's very, very low. I would say negligible, but it can occur. And I was meaning to take these two slides out, but there are some other adverse events, but they have been the same between overall. These were adverse events requiring hospitalization, but mostly they were due to unrelated conditions or conditions not related to vaccination. And some other unsolicited major events. The lymphadenopathy is probably real, but 67 out of several million doses, not a significant number. And the overall adverse events requiring hospitalization were equal in the control group and in the vaccinated group. So almost certainly unrelated to the vaccine. Returning now to the allergic issue, if you do have a history of an anaphylactic reaction to any vaccine, you really need to consult with an allergist or immunologist or a specialist before proceeding. And if you do proceed, be sure to be observed for 30 minutes rather than the standard 15. So overall, in summary, the overall effectiveness as measured by clinical cases, not mortality, because there really wasn't any mortality in either the vaccine or placebo groups, but the severity of cases was much less in the vaccinated group, and the vaccinated group was highly protected, as you can see. And that protection extended to the group over 65. The other vaccines that are out there have had variable results. The AstraZeneca overall was relatively low level of protection, but a lot of that was because they tested it in South Africa, and as I think everybody's aware, the South African variant wasn't as well neutralized, at least in the case of the Johnson & Johnson. The AstraZeneca had an issue because when they gave a half of the normal dose to the first dose, they actually got a better protection than if they gave a full dose the first time. And it's believed that the reason for that was because people made antibodies to the adenovirus coat or shell, so rather than to the COVID-19 material. And so it was difficult to evaluate, and obviously they need ongoing studies, and it's not licensed here yet. Novavax looks good. They're just too small numbers for these other vaccines to get any feel for how well they're going to perform in the older age group. So, in summary, this is a pandemic. It is unprecedented. It has outlasted what was experienced back in 1918, and it is still a serious issue and situation. We do understand it for the most part. We know what to do, but I think it's so widespread, it's unlikely to go away, and probably will evolve over time to be like many of our other common respiratory viral infections. At least let's hope that that's where it heads. But until then, it may be we're going to rely on vaccines and on recurring or needing to revaccinate if the virus changes enough. And so far, so good in terms of protection, but that may be dependent on the virus staying the same, which it obviously isn't going to do. So maybe someday we won't be playing social distancing hopscotch, and I'll take questions at this point, and thank you.
Thank you, Dr. Rand. Is it okay if I stop sharing your screen?
Sure.
Okay. All right, we're back. Ed Wilkinson, do you want to make any comments before we go to questions?
Oh, I'm sure there's lots of questions. Well done, Dr. Rand. I really think you covered it quite thoroughly. I think we all know that we got to get the vaccine, we got to get it in our arms, and we got to get that second dose. And otherwise, so far, so good. But let's take questions. Julianne, would you take questions? We'll see how it goes.
Ken Burns, go ahead.
I echo Ed's plaudits. I thought it was marvelously clear and well delivered. I have just one question for clarification about the Novavax. I thought that they were trying to make pseudoparticles out of the purified proteins that they were producing in culture, so that it looks like an empty virus. Can you clarify that, Ken?
No, I didn't really spend a great deal of time on that particular product, but just sort of took what I could find and assumed that when they said subunit, that's what they used. But they may have done some more modifications that I'm not aware of.
I think they're trying to do the same thing that was done with the papillomavirus vaccine, Gardasil.
Okay, makes sense.
All right, thank you. A question from chat. Does blood type matter?
There has been some data on that, supposedly an increased susceptibility to infection itself, maybe not to severity, but to infection with blood type A. And I think that that may be an association because in the chromosome where the blood type is coded, there's some immune genes that are nearby, and so it may be a marker for changes in those immune genes that alter susceptibility. So there has been some data suggesting that, but the other blood types are relatively less affected.
Okay, thank you. Ellen March, go ahead.
Hi, Ken.
Hey, Alan. There you are.
Very nice illustrations. I like your visuals. They were really helpful. I wanted to ask you, I've heard some words about the Regeneron monoclonal antibodies being used. What's the current thought?
Good question. I think for mildly symptomatic people, it's reasonable. There's been some speculation that it might be driving selection toward viral strains that are resistant to it or have modified spike proteins, and I guess that's theoretically possible as well. I didn't look into the data on that very carefully, but there has been discussion along those lines. They don't do much once you're seriously ill and intubated in the hospital, but in the less ill situation, they probably do make some sense.
Thank you.
All right, another question from chat. How long after second vaccine does it take for antibody production to max out?
It looks like it reaches a maximum probably 1 to 3 weeks or 4 weeks after the second dose. So it's pretty quick. That second dose takes advantage of the fact that the immune system is primed and ready to respond to that antigen with sort of heightened sensitivity. So yeah, I would say based on the data I've seen, it's about a couple of weeks after the second dose where you reach your maximum.
Okay, thank you. Shirley, go ahead.
That's a great talk, Dr. Rand. I'm wondering if you could talk about putting people in the prone position, how that helps with aeration, and whether that could be extrapolated to other breathing problems.
Well, my lack of experience in the intensive care unit is going to show through. I don't know how it changes the oxygenation and to improve it, just that it does. So I don't know what the mechanism of that is. And I also I'm not sure whether if you had a non-COVID-19 respiratory failure, and, the whiteout in your CT scan, whether putting patients in the prone position would help. I would guess it probably would. But I don't know the extent to which our intensive care doctors are doing that for non-COVID related patients.
Thank you.
All right, back to chat. Any comment on vitamin D3 as a preventative? And if so, any recommendation on the amount? If effective, it could be a recommendation along with masks and distancing. Also, how soon will we know about the need for continuing vaccinations?
So that was vitamin D,
D3?
3? Yeah. I had not seen any convincing data that vitamin D made any difference. It's been looked at in a number of different viral infections, and generally, may produce effects in the laboratory, but it doesn't seem to translate into general human populations. In terms of the need to revaccinate, obviously that's only time will tell. I'm assuming that, and I think it's reasonable, we'll be doing ongoing studies to be looking at vaccine antibody levels over time, and probably we'll get recommendations from a variety of sources, probably the CDC and WHO and Dr. Fauci, about when we should need to start considering revaccination. Certainly if the virus mutates, and if the mutated virus is less effectively neutralized or not neutralized in a significant number of people, they're going to probably recommend revaccination with a new vaccine. And I know Moderna for sure is working on it, probably Pfizer is too. One of the things about these delivery systems is all you have to do is, swap out the sequence and you're good to go with the next prototype. So they're working on it, and a lot is going to depend on how fast that South African strain spreads within the United States as to what kind of recommendations there will be. On the assumption that that doesn't happen, or doesn't happen to a great extent, then the question is going to be, at what point does the neutralizing antibodies fall to such a level that you need to boost them back up? And I don't know the answer to that, but I would guess it's going to be roughly every 2 years, you're probably going to need a booster, just based on the biology of the non-COVID-19 coronaviruses.
Thank you. Rick, go ahead.
Thanks. Given the extraordinary results of the studies, particularly for Pfizer and Moderna, how have the companies dealt with the ethics of continuing the studies and giving some of the people placebos?
Well, some of the people have taken that matter into their own hands and dropped out in order to get vaccinated. I think the companies are hoping, and I don't think they can't force anybody, but they have not turned around and offered the vaccine to those who got the placebo. They're continuing to follow people, and ethicists have debated that question as to whether it is ethical to do that, just to continue to follow people. But at the moment, I guess through inertia or lack of a positive approach, that is what's happening. But the ethics are a matter of debate for the ethicists and everybody to make up their mind.
Okay, thank you. We have several more in chat. What are your thoughts about the idea of giving everyone a single dose at this point?
I have mixed thoughts. At one level, it probably would introduce a level of protection more widely, but it would be a low-level protection that wouldn't last. So I'd be worried about the longer-term effectiveness, and I'd also be worried about whether it could select resistant versions of COVID-19. And so my preference would be to stick to the recommended 2-dose strategy. But that's again, debatable, and a lot might depend on the situation that a country finds itself in, or a region finds itself in. I think at the moment, with the number of cases going down, we may be in a window where we can afford to wait and get everybody 2 doses.
All right, thank you. Would you please comment on the nasal spray such as sanitize?
I'm sorry, the what?
Nasal spray such as sanitize?
Had not seen much on that, so I'm not really.
Not sure whose question that was. If you still-
You know, people have discussed or talked about various rinses, mouthwashes, topical things, or topically acting drugs, and or acting materials. And that would sterilize the surface for a period of time, but these viruses are inside the nasopharyngeal cells, and you may kill off the top layer with a medication like that, but the cells are just going to replenish the supply of virus fairly quickly. So it might temporarily reduce things, but it's not a permanent treatment, I don't think.
Okay, we still have some more questions. Are you okay, Dr. Rand, to keep going?
Sure.
Okay. If you are vaccinated, how likely are you to be able to be contagious to others?
Well, far less likely. I mean, let's assume you've gotten both doses, and you know, you do down the road contract an infection. There's some recent data showing that the levels that you produce if you've been vaccinated are actually almost, well, in this experiment or in this observation, they were really only about 4-fold lower than people who had not received the vaccine or the full benefit of the vaccine. But that's very early and preliminary data, but I think the bottom line is that if you will, that asymptomatic infection after you've been vaccinated is possible, and that you could be producing enough virus to spread it to someone else. And I think it's a good argument for continuing to have social distancing and wearing masks in public, particularly indoors where the viral spread is most likely. But it would reduce the amount of spread overall, just because the virus doesn't replicate as much in vaccinated people.
Okay, David Pauliger, if you'll unmute and go ahead.
Since receiving the first dose of vaccine, I've been receiving a weekly questionnaire from the CDC by text message inquiring about symptoms from the vaccine and making sure that the second vaccine dose has been scheduled or received. Do you know how long they're planning to keep this up?
No, I did. How did you end up getting those? What, were you in a study?
David, are you there?
Do you hear me?
I do now, but I didn't hear your answer. Were you in one of the vaccine studies?
No, it just came by text message a week after I received the vaccine.
Where did you get the vaccine, I guess was my question. Who gave it to you?
University.
Oh, I have no idea how you got on their hot list. None of us have gotten anything like that I'm aware of.
All right, let's go to chat. Do we know yet which vaccine, Pfizer versus Moderna, is most effective against the South African variant?
Well, the data so far, according to each of the manufacturers, suggests that the Moderna has better neutralizing antibody for the South African variant, that it's really quite good, about maybe as half the titers were reduced, or the effectiveness was the laboratory measurement of the neutralizing titers were down by about 50% at most. And that means that you really have plenty of neutralizing antibody for the South African variant if you got the Moderna. The Pfizer was reduced by about 80%. So it's maybe not as effective. And of course, if you're less effective in terms at the peak of your antibody titers, as those fade over time or go down over time, that's when you may run into problems with susceptibility.
All right, Roy, do you want to make any comments about industry can respond to the pressure?
Yeah, I think in terms of the inequity or inequality between supply and demand, rather than looking for an alternative of a single shot, I think industry is capable of meeting the demand fairly promptly. Industry can gear up.
Yeah.
Okay, and Ed Wilkinson, you want to make?
Well, I was going to respond a bit to Rick Gold's question about what about the placebo group. Kate and I were in the Johnson & Johnson study, and I discussed with the PI before we entered. I said, if a vaccine becomes available to us, we will go and get it. And he said, that's okay, you can do that. And I'll check with Johnson & Johnson as to what they want to do. So indeed, we got access to the Moderna vaccine. And so I contacted him and he said, well, the decision from Johnson & Johnson is we're going to keep you in the trial. We're going to continue inquiring twice a week how you're doing and do the blood tests and such. So we're not going to drop you out. We're going to put you in apparently a third category, which is a group that gets a vaccine, but it's not the Johnson & Johnson vaccine. And I think that's a very, very ethical way to handle that. Let me just say, Ken, I really appreciate your presentation. Very comprehensive, very understandable. I think we're all hoping the best that we're going to avoid the COVID if we can. But I know that I and many sincerely appreciate your continued work in this area and the great groups over at the University of Florida and others. And I notice Ken Burns has a comment or question. Ken?
Well, I think with regard to the 1 dose versus 2 dose, I characterize the 2 dose as policy directed by science, and the 1 dose is policy directed by panic. And it's been very interesting listening to Dr. Fauci respond to this question. And he said that we have the data for the 2 dose, and we're going to continue going that route. And since he's the chief advisor to the president, I think it's an interesting discussion to have. And, you know, ethicists are really interesting. What they're talking about is great sort of in the abstract, but if you're the person as an individual, it seems to me you may have a very different response to some of the conclusions of the ethicists.
Okay, if there are no further questions.
On a more personal note.
Excuse me, Bill Kim has a question. Yes?
Bill Kim has a question for Ken Rand. On a more personal note, Ken, are you going to Health and Fitness Center these days?
I'm so glad you asked. Actually, no, I have not gone back, although I have friends that have, and they say, oh, it's fine, and probably is. I think, you know, the first thing we did when the lockdown loomed was to buy a used treadmill and a used stationary bicycle and set up essentially a home gym. And, you know, but eventually I do plan to go back, but not right away.
All right. Well, thank you very much, Ken. Keep up the good work, and everyone, thank you for attending. This is our last Medicine Matters program, and we look forward to attending next year.